Hello, everybody. My name is Rich Kaufman. I'm Education Coordinator here at EMS West, broadcasting today from EMS Update 2025. The topic of conversation now is pre-hospital blood administration. With me today is Dr. Vincent Mosesso from UPMC and Executive Director of Ambulance and Chair Service in Washington County, Pennsylvania, Larry Pollock. Thanks, gentlemen, for coming.
Thanks for having us.
So, as part of the Pennsylvania pre-hospital blood program and as far as the protocols, we have been very fortunate to get pre-hospital blood out to different agencies across our region. Mutual Aid in Greensburg, Pennsylvania, the City of Pittsburgh EMS in Allegheny County, and also with Ambulance and Chair. The one thing interesting about Ambulance and Chair, if you don't know, is they're in Washington County, near Washington, PA, based out of there, and cover many municipalities in Washington and Greene County. So their dynamic is quite different. Other than being urban, they have a mix of both urban, suburban, and rural, which makes the challenges of pre-hospital blood a little bit more. Dr. Mosesso, can you tell us about the beginning of the pre-hospital blood program?
Beginning?
Yes.
When the new state protocols came out in early 2024, we felt that Ambulance and Chair would be a great location to extend this beyond, City of Pittsburgh was already doing it, to get the residents there, because as you said, we have rural, suburban areas, a lot of need out there, a lot of highways, and so it was felt that this would really benefit a lot of the patients, and they have longer transport times to get to a trauma center. So Larry was very enthusiastic about saying, let's move forward with that.
Can you tell me a little bit, if we can just take a step back and talk about the protocol itself, or how Pennsylvania specifically kind of got into allowing pre-hospital blood?
Okay, yeah, sure. I think that grew out of the growing experience through trauma care in general. We began having research studies that showed that we were actually hurting patients with saline. We used to give the 2 liters of saline, and that could actually kill someone. And it became realized that blood was a much better option. So first the hospitals started using blood, and now it became used in some centers around the country, a couple places, San Antonio, New Orleans. And so luckily, Pennsylvania was forward thinking and added it in as an optional protocol for where it would be feasible to do in Pennsylvania. And we realized that giving blood early on can save many lives.
So I think a couple big points within that are, one is because blood is such a precious commodity. So for those of you that have the ability to donate blood, please do, because there's always a need for blood. The next part of it is because it is such a precious commodity, we want to make sure that the right patients are getting it at the right times. So if your agency wants to get involved in pre-hospital blood, the one thing that you should do is reach out to your regional council. It is part of the protocol, and your regional council can help you through the process. So for the EMS West region, we have a blood committee that we call, that Dr. Mosesso, Dr. Martingale sit on with us, along with some EMS West staff, that review the agencies that want to become part of it. We don't want to be exclusive to any agencies, but we also want to make sure that not every agency may have the need to carry blood. So Larry, can you tell us about your starting of the blood program within the Ambulance and Chair Service?
Yeah, absolutely. So what I'll tell you, Rich, thanks for having us here. This is the regional aspect of this is very important. When we looked at this, we identified some partners down in the Mon Valley area, as well as the different areas in our service area, some folks in the South Hills and things, as far as partnering with them, coming up with a regionalized approach for dispatch of this, as well as when we're going to send the blood, how we're going to get that there, and the training. I think regional conferences like this is very important, not to reinvent the wheel. We actually went and did a couple of conferences where we talked to some folks in Texas and medical directors and EMS leadership, and looked at the pros and cons of carrying blood, the deployment of it as far as that goes. So we'd be happy to also work with the region here in southwestern Pennsylvania or across Pennsylvania to share some of the things that we learned from this program.
So the one approach that the region has had with medical director involvement is that we wanted to kind of create a system of how can the blood be deployed. And there are agencies that want to have the ability to carry blood in EMS vehicles, whether it be a supervisor vehicle or an ambulance itself. Do we have agencies that want to know how to administer blood, but maybe only do it for the purposes of I'm agency A and agency B might be mutual aid or ambulance and chair, but my people, my staffing are going to be trained on it, but we're going to get the resource from somewhere else. And then option C would be that if we have an agency that says, due to the need for interfacility transports from community-based hospitals to tertiary care that need blood, either medical or trauma-related, is that an agency could say, okay, we want our people trained, but we want to make sure that we're only doing it on that emergent kind of interfacility. I think one of the take-home messages with the training is the training needs to be the highest level of training. You need to know what the components are as far as your logistics with your blood bank. You need to have the right equipment for the safety of the blood because it is such a critical resource. We don't have the ability with blood like an AED where we can just put one on every ambulance. Right. You can't put a cooler on every ambulance. So we need to make sure that people are trained to the highest level of what can go wrong in this process. And we don't want to, necessarily not pay attention and let the blood expire or have a contamination and not have a patient issue as well. Can you tell me a little bit, Larry, about the infrastructure that you needed to do or what an agency should do to make sure that they can have the safety of the blood supply?
Yeah, so the biggest task that we have as far as equipment checks on our ambulance is the blood. Come in for a normal shift, the paramedic checks your truck, cleans your truck up, and kind of gets out the door, and that's that, right? With the blood, we're actually checking the blood every 4 hours, and that's round the clock, midnight and throughout. We have documentation software that we use. We also elected to purchase a cooler that we're going to talk a little bit about more in our lecture coming up, that monitors real-time notifications as far as if the blood goes over a certain temperature, that we get that advanced notification because we do not want to waste blood, right? Blood is so precious. We wanted to be a good steward with the blood, so when we did this, we actually did a series of blood drives, and we had a team that does that because we're going to have increased use of the blood. So all those training mechanisms that you talk about are so important as far as that goes.
So, and not to tell people not an agency that they shouldn't be, but there is a financial investment with the coolers because you just don't go to a Walmart or a Target and buy a picnic cooler and put ice packs in it and put blood in it. That's just not simply how it needs to be monitored, correct?
Yeah, no, absolutely. So, I think each agency is a little bit different. There's different ways that you could get to that. We're a very busy agency that there's times that we can't keep the blood in our station. We have to keep it actually on board of the truck because of the movement that we do. We have 7 stations throughout Washington and Greene County, and it's not unheard of for you to start at one station and kind of move to another when we do our system status management. So yeah, it is very challenging as far as the financial impact of it. We're currently at 3 coolers, and cost of the program we're thinking is somewhere around $75,000 for all the infrastructure that we put into the training materials and everything there.
Okay, so there is training available, at least some of the initial training is available on PA Train.
Yes.
For Con Ed purposes, for anybody. You do not have to be a paramedic to take that training, so we would like people to, if you're an EMT, don't just say, hey, I'm just an EMT. You can learn about the blood program as well. So please look into that program on PA Train as well. As far as the education, so Dr. Mosesso, if you could talk a little bit more about the education. So I think there's a couple different components to that education, but how did you kind of attach that being the medical director for a service doing blood?
Exactly, Rich. So the PA Train is a good program, gives you good foundational knowledge. We wanted to really make sure that our paramedics had a thorough understanding and to be able to ask questions and get into maybe some concepts that we didn't even think about putting on the training. So we did in-person training. I developed a training module, a PowerPoint, and we did an in-person didactic talk for them. We're able to answer questions and discuss things that might come up. And then what's very important, I think, is there needs to be a practical portion to the training as well. So one is the tubing for the blood is different than standard IV tubing. And there's a very specific way that you're supposed to load the blood up, and you have to load saline with it. And there's multiple locks on where you can, controls on the tubing. And then there's the cooler too. You have to be some understanding of the coolers and how they work and how they are in operational mode and looking for any error messages and stuff. So all those things require a practical session if you're going to be actually handling the blood.
That is one thing that came up early on when we were moving this training forward from the regional standpoint, and the medical directors at the region is you have to have the hands-on training. You can't put this equipment out there and watch one PowerPoint and it be enough. You have to understand the medicine behind it, but you have to understand how to do it. Because again, it's very precious. You wouldn't, throw a $40,000 cardiac monitor down a set of steps. You're not going to, check the temperature of the blood or have a monitoring system and let that precious commodity expire.
These, interjecting on the training, these are low volume situations, right? We don't use blood often. I think we've had about 16 cases now, 14 cases now, a couple interfacility trips with that. These are going to be very sick patients, obviously. So, some things we do with the training is we'll have our on-duty supervisor kind of go out, every few weeks and just monitor some folks, kind of explore, get their hands on the equipment. It seems to really keep us on our skills as far as that goes.
So the question, I know the answer, and I think some other folks would know the answer too. So when we first started talking about blood, the knee-jerk reaction is we're going to use this for trauma patients. We're going to use this in situations of people that are entrapped or impaled that might be a difficult rescue, and because of that, their condition can deteriorate, so we're going to move blood to the scene. What have you seen so far with medical patients versus trauma patients? Like, where's your percentage roughly on the administrations?
Yeah, it's actually a pretty even distribution. What's interesting, you're exactly right. The concept of blood in the field was really thought of for severe trauma, and like you said, entrapped patients that are going to be at the scene for a while. But we've had, about a third of our cases are those multi-system trauma, I would say. We've had a third that I would say are sort of localized bleeding. We've had surgical wounds bleeding, post-op dental surgical bleeding, and some extremity trauma, like a near amputation and stuff. But then we've also had another third that are medical cases, GI bleeding in particular, but we've had several obstetrical bleeding, postpartum hemorrhage, spontaneous abortion, where we had very severely ill patients in shock from that bleeding too. So the blood has been used in a variety of ways, and maybe even more than we thought or expected initially.
And I think that's a good point, is we don't want to, if your organization does have a percentage of trauma calls, whether they're blunt force or penetrating trauma, don't just carry it for that reason. Like, we can help a lot of people in multiple situations, and it's things that probably, like you said, we didn't envision when we were going forward with a blood program. As we start to wrap up, can you tell us a little bit, Dr. Mosesso, about the interaction that you specifically, but your organization, your medical directors will need to have if you go forward with the blood banks, whether it be Vitalant in this area or the Red Cross, as far as being able to get the products, because those meetings are very important. They are very, stewardships of a very precious commodity, but their job also is to get this commodity to people to save lives. So can you tell us briefly a little bit about that?
Yeah, and I want to fully endorse what you said about it being a precious commodity. This is a privilege. This is a great advance for EMS to be able to give blood, but it also is a privilege we have, and we have to take that very seriously. And that's part of the blood bank's, responsibility, is they have to make sure this blood is being utilized. It's not going to be wasted. So they have a lot of guidelines and say regulations we have to follow, and they also confirm that our policies and procedures are in place. So you are going to have like a number of meetings and follow-ups and emails with the blood bank management personnel. And a lot of that may not all be necessarily on the physician level. It can be, you know, the service management or like a dedicated person who's in charge of the blood program. There's a lot of details that have to be worked out and stuff, but that interaction and collaboration with the blood bank is essential because, I mean, they control the blood, so we want to work with them as collaboratively as possible, and they can help guide us. They let us know what is necessary to preserve that blood properly.
What I'd add to that also is if your service is looking to start the blood program, start early. This was about a 6 to 8 month pretty intense process for us as we were building protocols. And that was even leaning on partners as far as that goes. Both internal protocols, how we exchange the blood, how we go about interacting with the blood bank, in the distribution of that. So I would tell you start early. And the other part, just to echo, is very important is as you're starting that planning, get your medics trained so that they can do the interfacility or they can assist folks that have the blood when they come out, whether that be our medical partners or a service that does have carries the blood on the ground. The more knowledge that you have, the more people that can work as a team approach to this while you're waiting on to having the blood yourself is very valuable.
There was one. Go ahead.
I was just going to add one thing that is kind of physician specific with the blood is that when a blood unit is administered, to replace that blood, the blood bank will require a physician to sign a form that's actually approving the use of the blood that was already given. It sounds odd, it's retroactive, but it's like the same in the emergency department. If we give blood without cross-matching the blood, we have to sign this form that says, like a physician said, it's okay to give that blood without doing the normal process. And so we had to work out a system, and we finally got that, but I'll be willing to help and talk to any medical director because usually it's going to be the medical director that has to sign
the
that
agency
form.
medical director,
The
not
agency.
just the medical command director,
Right.
just to make that clear.
Yes.
You know, early into this process, it was literally finding Dr. Mosesso to get him to sign off on. Obviously, we've tried to operationalize that a little bit differently now, but yeah, having a team approach on this is important. We did a task force at our service. We have somebody that manages the blood program. Annie King for us does a great job, so I give her a little shout out. And it's definitely a team approach, but worth it. The fruit here is when you have some of these cases that we're going to talk about here just in a little bit during our lecture, and seeing the patient outcomes is just a great thing.
Very good. I thank you both for your time. Larry from Ambulance and Chair, Dr. Mosesso from UPMC, as well as Medical Director and part of our Medical Direction Committee at EMS West. For all of you out there, EMS providers, laypersons, if you do have the ability to donate blood and you do not have a medical condition that is prohibiting you from doing that, please do that. You do not realize the difference that a patient could have from a 30 to 45 minute time frame of your donation. And blood only lasts, 42 days? Do I have that correct?
Yes.
Okay,
Yes.
so approximately 42 days. So these blood products, if they are not used, they are discarded. We don't want to have to discard them. We want them to be used, but we also want, that's why it's called a blood bank. We want to be able to have volume there to replace it, and it's an ongoing process.
And we do return it before it expires, so that
Yes.
blood isn't truly
so
wasted,
that is,
it's used in the hospital.
That is one operational thing, again,
yeah.
that is part of that. So thank you for your time. For those of you that are here on site today, 3 o'clock today, Dr. Mosesso will be expounding more upon the program, as well as Larry Pollock. If you have the ability, donate blood, and we will see you soon.
Thank you.
Thank you so
Appreciate it,
much.
yes.
Thank you.